morning.
Good morning. Is that working?
Perfect.
Hi.
Hi. You're hiding.
Yeah, well, I just had a shower. It's so wet.
Show us your jammies. I always like my Friday mornings like do everything all at once, and I like dive out of the shower into this tutorial and I always look like a drowned rat, but hey, at least I'm not wearing a towel.
Well, I'm not in a towel, but let's see if I can get it to work.
It's fine. I'm just now looking at the chaos behind me. Somebody's pulled all the feathers out of my cushion. Oh no. Skippy dog, leave it, please. Thank you. How has everybody's week's been?
Yeah, pretty good.
Very good.
Too much? Not too much on.
Hey?
Not too much on. I mean, first, just a couple interesting cases, but nothing super interesting. So just standard.
That's nice. Yeah, super interesting is never actually a good thing. It's a good thing
it's actually
in hindsight, but
yeah.
I actually had a case yesterday that was one of those cases that you see only a couple of times in your career, but we talk about it all the time. So I'll run through it. It actually had an abdominal effusion. So we'll use that as a model for our discussion on that one. I'll actually see if I can get some ultrasound pictures up. Let's see. All right, so the topic of today is just analyzing fluid, basically. So the chapters that we're covering are urinalysis and then joint, abdominal, and thoracic effusions. I don't think urinalysis is very interesting, so I don't want to spend too long on that unless somebody's got any specific questions.
Yep.
Agree?
Yeah.
Yeah. The main thing that I think is worth kind of the thing that I sort of see in when I'm going around to practices and working out cases with other vets is that a lot of people don't do sediment exams fresh. They often send out their urine. So what might you miss out on if you're not looking at a fresh sample of urine?
Like casts will degrade.
Good. And what's the significance of casts?
It depends on the type of cast. Like I can't remember which one now, but one of them actually tells you tubular injury.
Yeah, absolutely. So there's a few of them that can signify tubular injuries. What are the different types of casts?
Granular, waxy, hyaline, which are normal, I think. Hyaline.
Good.
There's protein.
Yeah, that's perfect. Oh, I found that ultrasound image. It's a good one. Sorry. So if you had, say, a really raunchy inflammation in the tubule, due to tubular damage, what do you reckon you'd see in the tubule? Granular, waxy, and hyaline, what are they made of? You know?
I don't know if I have a good enough answer.
So granular are actually made of inflammatory cells usually. So if you've seen granular casts in like dog's urine, for example, it usually means that there's active tubular inflammation because there's a lot of cells being kind of sloughed into the tubule, and there might be a combination of inflammatory cells and epithelial cells, but that's usually an indication of quite active inflammation. Nor casts ever normal, I should ask.
Some can be, I think. A few are not a problem.
Yeah, exactly. So we see usually hyaline cast, like quite smooth cast, and it's just made up of the normal kind of protein, the TAM horse wall proteins, which are like normally exudated into the tubule. So you're allowed to see less than 2 per low powered field when you're looking on your urinalysis. So if you're seeing 1 or 2, it's fine per field. And they've got to be kind of pretty smooth. But if you're starting to see really granular looking ones, what does that signify?
Like renal injury, is that what?
Yeah, exactly.
Tubular damage.
Yeah.
Yeah, and it's actually one of the, this is, I'm quoting a study from pre-cystatin B availability and actually probably like borderline pre-SDMA. But the first sign of renal injury is presence of casts in the urine. So it's the earliest marker. So if you, for example, have a patient who's had a nurofen toxicity or some sort of other renal injury, then you can really get an idea of like whether they need to be sort of hospitalized based on a fresh sediment exam. But if you send that out, a lot of those casts will degrade and we'll lose that information from the urinalysis. It's just very time consuming. Teach your nurses how to prepare with the urine. There you go.
It's disappeared and came back.
Yeah. So we were just saying that casts are actually the earliest marker of renal injury. So if you're sending your urine out, or if you've got a patient that's got a known renal injury and you're sending your urine out, you might be missing that information. And what I'd love to be able to do or ask people to do is to collect 2 free catch samples a day in high-risk patients and just do a fresh sediment exam every time and screen for casts. Practically that never happens. Like we're always just doing creatinine monitoring and seeing whether that's going up or SDMA. So that's kind of casts. What else do we lose by not doing a fresh exam? Or what else might change? What about pH?
Yeah, pH can change, but like I don't know how much relevance to give pH in a urine, except unless there's like urolithiasis, then yes, pH is you sort of gauge what may be the stone, but otherwise, I'm not sure if you really pay attention to your pH.
Yeah, it's a little bit variable on your dipstick. So it's not, we don't have the most accurate in-house ways of measuring it. But pH can definitely change. And what changes when pH changes?
Types of crystals that we're seeing in the urine.
Yeah, I think that's the more significant component. So with temperature change and pH change, you'll see different crystals forming at the solutes coming out of solution. And that can be quite misleading clinically. So if you've got a dog that you've seen a stone on ultrasound and they had a urine full of struvite crystals in-house, you might get calcium oxalate crystals by the time it gets to the lab. So, and then it's going to change your clinical approach to that patient.
What kind of timing are you kind of, I guess, referring to when if you get a sample back from the lab and there's calcium oxalate and you're like, is that significant or not?
I don't think you can ever call.
Never.
Yeah, so crystals from a not a fresh sample, I put very little weight on them because there's actually no correlation. So if I haven't done an ultrasound and seen a urolith, if I'm just doing a urinalysis on a patient with stranguria or something, the crystal urea is not predictive of urolithiasis at all.
Yeah.
So it's then hard to draw any significance from the presence of crystals, particularly when they might be artifact from processing. If you're seeing what crystals are like always significant, what aren't going to form if it's not in the urine to start with.
Yeah, bilirubin crystal.
Good, yeah.
But I think like bilirubin in dogs to an extent is again not really significant. In cats, it's always significant, I thought.
Let me open this bilirubin.
Like 1 or 2 like bilirubin crystals in a dog, I thought was fine.
I think you can. I think you can get like a slightly increased bilirubin like in a male dog on the strip, but not necessarily crystals. But I'm not sure.
So yeah, dogs you're allowed to get a 1+ on bilirubin on your dipstick, but I'm not sure about crystals to be honest. I don't know if I've ever really looked at urine and gone, that's a bilirubin crystal. Has anyone?
Yeah, like once or twice. But
are they very hyperbilirubinemic animals?
They were, yeah.
Okay.
Yeah. And then by the time it got examined by the lab, everyone was like, was it bilirubin? I was like, I'm pretty sure.
But, yeah, interesting. Yeah.
Urate will be the other one, except in Ali's.
Good. Yeah. So there's not really any reason why urate, or there's one more that we see, not commonly, but in a career you'll see, that shouldn't really be in urine unless it's a problem.
Cysteine crystals?
Excellent. Yeah, so they're quite distinctive crystal morphology, so they're a good one to be able to identify under the microscope. But it does rely on them coming out of solution and forming crystals. Yeah, so that's I guess the benefits of doing a fresh urine sample. Is anyone using the cystatin B test in their high-risk patients?
We have the capacity to, but we haven't really yet. I know that like we've tacked it onto a couple profiles, but not actually the ones that probably should be getting it, like the ones in ICU. So not really.
Yeah. I think it's a really interesting test. I think it's got a lot of potential, and I'd love to see it applied for exactly those high-risk patients, because I don't think it's that. I think it's great for prediction of early renal injury, but it's not got any indication once we've already established there's renal injury. Yeah.
They talked about it at the pathology conference last week, which was really good, but I don't have my notes immediately with me to bring up what the other possible uses might be.
Yeah. Yeah, it's interesting. I'm watching this space, but I'm not in the habit of recommending doing it. But when it just takes a while to change your habits of like, oh, I've got an acute renal failure patient, this is what I'm going to recommend, kind of thing.
Yeah.
Proteinuria is such a big topic. But the main thing I want to cover when we're talking about assessing urine in-house, what might cause you to falsely think there's a proteinuria when there's not actually? Or I should say, what might make you think there's a renal proteinuria, significant renal proteinuria, if there's actually not?
If there's hematuria.
Yes, good. Yep.
Or can you have it with, like, if you have marked leukocytosis or something?
In the urine? So in theory,
Pyuria maybe.
I don't know about hyurea. Let me consult my table. Sorry, there's actually a table in Energer which shows what might cause artifacts for each of the dipstick results. And we are currently talking about protein. I don't have urea, but interestingly, high pH alkaline urine can artificially lead to an increased result on your dipstick.
Yeah, okay, yep.
Yeah. On a dipstick, I should be very specific because there's a few methods of measuring proteinuria. But I think anytime you're detecting proteinuria on a dipstick, you should probably be sending out for a UPCR. In theory, hematuria, inflammation in the lower urinary tract will cause an artifactual increase because it makes sense, right? There's more protein in blood than there is in urine. It's actually a paper that came out recently that said that that's false, that you won't get an increase in UPCR, a significant increase in UPCR to clinical, like changes in your clinical decision making.
Yeah.
With hematuria and lower urinary tract infection, which just changed things a little bit as far as, because it's nice to just be able to do all the tests on the one urine sample, right, rather than treat the UTI and then test again.
We've definitely had conversations about that as to like how significant is it when you've got like maybe like an asymptomatic bacteriuria, but is it actually the thing that's causing your change in protein or not? But yeah, and then that paper came out and we were sort of like, maybe it doesn't matter, but not sure. Nobody's really convinced either way.
I know, and it just doesn't really make logical sense for there to not be an increase in protein. If there's an increase in blood, there has to also be an increase in protein in the urine. And maybe that you just can't get enough hematuria to result in like a 2+ UPCR. But in theory, then the gray zone, like maybe the normal range with hematuria needs to be a little bit higher or something.
Yeah.
But I think if you're getting a UPCR of 8 in a dog with hematuria, that's a renal proteinuria, So I don't think it's not worth doing. But I think I'd interpret a gray zone result with caution in a dog with hematuria. Makes sense. Anything else with urine? Do your fresh sediment exam, do your USG in-house, and other than that, and look for casts. in your high-risk patients. They're my take-homes for urine analysis, of which I do none. Oh, should we talk about glucose in the urine? Causes of glucose in the urine, just quickly. At what level will we get of what glycemic level will we get glucosuria in a dog versus a cat?
10 is coming to mind, but I don't know if that's the right number. Yeah.
Yeah.
I have 16 in my mind, I think, for cats.
Yeah. Yeah. So dogs like 10 to 15. 15, like most dogs, there's not that many dogs who can get a blood glucose of 15 and not have glucose in the urine. Whereas cats can go up to 17 without leaking, or without exceeding their tubular resorption capacity. So cats can get a fair bit higher. What's a reasonable blood glucose associated with stress for a cat?
It can be a lot higher than you think it should. So I think like, what is it, 20? Like,
it's actually reported up to 39.
Yeah, I was like, it's really high.
It's really high. And because they've got they're kind of glucose sensitive, so like they're really prone to just getting these like catecholamines, which is going to block all of the effect of insulin. And if they've just eaten, you might get a very, very high blood glucose. So it might be very reasonable to see glucose in the urine in a cat that's very stressed, either physiologically due to illness or because it's just visited the vet. But I think the most important thing is like stress-induced hypoglycemia is usually short-term. So we should be able to, it should be pretty low-grade glucose in the urine because it's not like it's accumulated over 8 hours when they're like holding onto their urine, and it shouldn't be sustained. So they're the things to kind of watch out for. And is there any artifacts of glucose? Oh, penicillin can cause an artificially increased result, and sulfonamides and cephalosporins. That's interesting. I don't think I knew that.
It's kind of useful for cyclists. Well, not useful for cyclosporins. I don't know how many UTIs they end up with.
Oh, cephalosporin. Sorry, it's like
cephalosporin.
Yeah, sorry.
Better.
I was like, yeah, hush. Sometimes you don't use, cephalosporin in UTI patients. I actually had a patient yesterday who's diabetic, and I wasn't even looking at it. I was there to do an ultrasound in another patient, and it had this huge ecchymosis at his injection site. And they just I did the CBC while I was there, platelet count 1. And I was like, oh, diabetic, like this is going to be a nightmare. And did a bit of reading, and there's an interesting new drug available called romiplastim.
Oh, yeah.
Have you used it?
We haven't used it, but we did it in Journal Club one day, and I didn't know if it was currently, it's like super expensive, and I don't know if it's currently available.
Okay.
Or I mean, we say expensive, but then L-asparaginase is X amount of money, and we use that fairly regularly, so I guess it depends on what we call expensive. But
can we get L-Spa again?
We got it.
Oh, that's cool. Good to know. Where are you, Sarah?
Sash in Adelaide.
Oh, cool.
But we haven't used it yet, but we have kind of talked about it, and I don't know, maybe there'll be one in the future that we'll probably not be able to get it in time, but we didn't really think about the diabetic side of it. It was more just, does this, the literature that's out there we could find that didn't seem like, one of them examined it at the same, they used it, but they were also using pred, and then it's like day 7 and they're like, oh, it was effective, and we're like, well, probably so was the first day. So it's a little hard to quantify how good their actual experience was. But it came up because we had some human immunologist patient that was like, wow, splenectomy is real old school for that. And we're like, sorry.
Splenectomy, did you say?
Yeah, well, I think it was just brought up as a possible option, and they were thinking we're pretty
old school, some people still advocate for splenectomy for ITP cases.
Yeah, I think that I'm probably one of them, but not until we've tried a bunch of things first.
Mm-mm.
Yeah.
Yeah. Not for ITP specifically, but definitely IMHA. There's dogs I'm like that, and I've always got nodular spleens, and I'm always thinking, is this histocytic sarcoma? Why aren't you getting better?
We had PEMA cases that we're now kind of advocating more for as well, obviously after you've tried all the initial stuff. But I know it doesn't make sense, but there is evidence out there for some proteome in the spleen that
Yeah.
can
Which
affect
cases?
PEMA,
What's PEMA?
like
Precursor.
precursor immune-mediated anemia.
Yes.
Sorry, yeah.
Yeah. I got distracted by the captions.
Oh, sorry.
I
Did
was
it say
like,
something?
it spelled it differently, and I was like, oh, I don't know
What is
that.
that?
Yeah, so I'm so far behind. Funny. Yeah, it's interesting. There's the spleen. There's just so many macrophages and histiocytes in the
This is
spleen.
an
So
interesting
you
thing.
take out a lot of the capacity for hemolysis by removing the spleen. Just buys you a bit of time sometimes. Get on top of it. Okay, let's move on from urine and move on to effusions. So there's a lot of like often you sort of presented with a patient with a swollen abdomen and you don't know obviously what's in there. I think there's a like, I'm not sure why, but a reluctance in a lot of clinicians to tap tummies these days. Like if you don't have ultrasound guidance and but you just get so much information from what the fluid is. And we get called to do a lot of ultrasounds on dogs with ascites. That's ascites is not an effusion, it's specific. Yeah, exactly. And it's often not ascites, it's often like a hemorrhagic abdomen that maybe, would have been better if it had been tapped. That, obviously
Earlier.
Yeah, exactly. Don't go sticking needles and everything. But if you don't have the luxury of having an ultrasound at hand and you've got a dog with a belly full of fluid who looks systemically unwell, then definitely I would advocate for sticking a needle in blind very slowly and just taking a sample. So let's just work through the different types of effusions that we see in abdomen and chest, and we'll sort of do them together because the mechanisms are similar. But obviously we'll talk about the ones that happen, the mechanisms that are different in the different cavities. So what is probably the most common type of effusion that we see?
Transidate or modified transidate?
Yeah, modified transidate. They're always
because none of them are over transidate.
Never. No, very rare. So what is the difference between modified and straight pure transidate?
Protein levels also, I think.
Yeah. So the cells are a little bit more variable, but the protein levels, the kind of the thing that tips it into modified typically. When you're looking at what the protein levels in a transidate, what significance can you draw from that?
Where it's coming from, maybe, like in terms of pre-sinusoidal, post-sinusoidal, sinusoidal, like that sort of thing.
Yes, exactly right. And for people that don't know what that means, can you explain it in more detail?
So pre-sinusoidal will come from gut, like before the sinusides. That's how I remember it, like in my head.
Yeah.
So essentially, most times, like it will be gut disease, like that's the most common. You can also get it with hepatic sinusoidal, so portal, like hypertension, causes of portal hypertension, which can be due to liver disease.
Yeah.
And then post-sinusoidal typically is after liver, so essentially heart is how I remember.
Yeah, perfect. So anything that's cranial to the liver. And there are, like, heart's by far the most common, but there's a syndrome called Budd-Chiari syndrome, which is essentially obstruction of the cava between the heart and the diaphragm or the liver, which we can sometimes see as well with thoracic masses or caval masses. So let's talk about pre-sinusoidal I might actually show you my case from yesterday. So I had a dog, 10-year-old Shar-Pei, presented with ascites yesterday. And they had it was like quite a large volume effusion, but there was a fair bit of kind of fibrin and stuff, and they had tried to tap it and they hadn't been able to get a sample yet. So we didn't actually know what we were dealing with when we met this case. Blood test showed, can you see my screen?
Mhm.
Great. Blood test showed an ALT of about 350, ALP of 600, bilirubin of 33. And most interestingly, an albumin of 21, like just mildly low, and a urea of like 1, like quite low. So obviously, if it was an ascites, I was thinking there was going to be a primary liver dysfunction.
Yeah.
Based on that, and potentially portal hypertension. So we did an ultrasound this dog. And I'll just, if you're not very familiar with ultrasound, I don't know how much ultrasound you guys are exposed to, but free fluid, black. And there was like a moderate volume, not huge, but moderate volume of free fluid. And this is the liver. Liver lobe should come taper like this. So it's fairly normal kind of shape. But stop that. Sorry. What do you think about the margin of this liver?
Very undulating. That's not
Very
normal. Like it's just
gross.
like that's not normal at all.
This liver looked like it was made of popcorn. Like
Yeah.
it was just so nodular looking, but very small. Like we had to dig right up under the ribs to see it.
So would this not fit with cirrhosis?
Yes. Yeah. Yeah, exactly. So the reason I wanted to show this is because you see a nodular liver like this, it could easily be a diffuse hepatocellular carcinoma. But typically the liver would be big because we've got an increase in cells. It could be infiltrative disease like lymphoma or a really severe inflammatory disease, but again, the liver size will be big. But when you've got a small nodular liver like this, we've lost parenchyma, which means there has to be a degree of fibrosis here. And then when you've got nodules like this, it's not uncommon for the liver to regenerate in a nodular pattern. So when we see nodules like this accompanied with an effusion and a small liver, there's not much else it could be. So given this dog's signalment was Shar-Pei, what do you do next diagnostically?
Tapping no, we've already got the fluid. It's just.
Yeah, well, we didn't have a sample of fluid, so we definitely tapped the fluid.
I'm sorry. Yeah.
Guess what it was?
Was it a modified transudate?
It was, of course it was. It was a little bit yellower because it had bilirubin in it.
Bilirubin. Yeah.
So what else do we want to check on ultrasound in this dog?
Kidney?
Shar-Pei kidneys.
Kidneys, yeah, good. They actually look pretty normal.
The like
Give us a clue.
no, I mean I was just gonna say like in terms of like portal hypertension,
Yes,
but you've
good.
probably got, you know, you're already looking at the liver, but the portal tracts and vena cava, I guess.
Yes, this was really, I found it really interesting because you almost couldn't see any vessels in this liver. Like they were so fibrotic and constricted. So there was definitely decreased blood flow, portal vasculature within the liver. And then the portal vein itself was like so full, yeah. And you could see that pressure backing up through the splenic vein and mesenteric vessels. And then in the caudal abdomen, you could see all of these new vessels coming off. So this dog was either acquiring or had acquired extrahepatic shunts. So this was kind of a slam dunk as far as like the mechanism of fluid development. So portal hypertension, secondary to sinusoidal cause of the ascites. So modified transudate. Could have been a pure transudate-ish, but because there's that sinusoidal component, probably not.
So was this protein rich or protein low protein?
It was mid-protein.
Okay.
Annoyingly.
I hate us.
I know. It wasn't a slam dunk for me. Because there's the combination of post-sinusoidal and sinusoidal when in these situations.
Because they can do either, right? Like hepatic can do either.
Yeah, exactly. So when it's kind of mid, it's sort of like, well, no, it doesn't help me. Okay, I'm going to stop sharing that one. So this dog, I was tempted to FNA the nodules in the liver, but I couldn't think of a reason why it would change what I was going to do with this dog. So I didn't. And I don't know if that was the right thing or not.
What did you do? Like, are we thinking amyloidosis?
Potentially originally it's a little bit unusual to get changes in the liver that severe without renal changes.
Okay.
But this dog's joints were really puffy. Like I wouldn't be surprised if amyloidosis was the inciting cause, but now it's chronic hepatitis and fibrosis, essentially. And the other thing with amyloid is that the livers aren't normally that small because it's adding to the liver, and it's not until the end stage that they start to contract down. But there are lots of reports, particularly in cats, of FNAing amyloid livers and causing fatal hemorrhage.
Hemorrhage, yeah.
Yeah. So I sort of, with that, signalment and that, I wasn't going to poke needles in it. Like there had to be a really demonstrable benefit to doing an FNA. So I'm not going to get a cytologic diagnosis. We're going to manage this dog for its presumptive shunting. So minimize the impact on his brain function and systemic ammonia levels. We're going to decrease inflammation in the liver as best we can with supportive care. We tossed up colchicine. We went to and fro with whether we recommended that because of the risk of colchicine is hepatotoxicity. We ended up electing, like, it's not going to reverse the fibrosis that's there. It's going to minimize progression of fibrosis. There's not that much evidence for that. But we didn't specifically recommend any anti-inflammatories because we don't have that cytologic diagnosis. And every anti-inflammatory we do is going to impact liver potentially. Or I shouldn't say anti-inflammatory, immunosuppressive as well. So we elected to not do those things with kind of consultation with the vet and the owner's appetite, risk appetite and stuff. But none of those would be the wrong thing to do, I don't think.
Would you ever advocate for laparoscopic biopsy of the liver in this case, like, or too risky?
Probably not going to change much, is it? Like it's already developed.
It's already in stage, okay.
Yeah.
There are dogs that, like, if I think the liver's like not diffusely nodular or there's like it's salvageable, like there's enough functional liver there that we might be able to reverse, keep this dog going long term, I would take the risk because there's a potential benefit for that.
Doesn't liver regenerate a little bit?
Yeah, a lot. And you only need 10% of your liver to be functional. But this dog's on blood test demonstrating he's got less than 10% of his liver functioning because we've lost albumin and urea.
Albumin and urine, synthetic function is,
Yeah, so even despite that kind of regeneration, like regenerative attempts it's made in all those nodules, we're still failing. Yeah.
And then would you ever use steroids for fibrosis? Like there's not real evidence, but then I know people use it, so I don't know where I sit because I don't know.
Yeah. It's very effective. So if I had a dog with chronic hepatitis and I was choosing between cyclosporin and pred and there was bridging fibrosis in that dog, I might go with pred over cyclosporin. But then I'd probably, once we kind of got on top of the inflammation and the cause of the progressive fibrosis, I might try and transition them to something that would mainly just make it easier for me to monitor the liver. Because you put them on pred and the liver enzymes go up. And
Who knows?
Yeah, who knows, exactly. So I actually have had very good anecdotal success with cyclosporin. It's my favorite medication for chronic hepatitis. But yeah, I sometimes have to use pred. Sometimes my bones tell me I have to use pred. It's so unscientific.
It's the gut feel, it's the experience.
It is, exactly. Yeah. But it's not, it's your bias, isn't it? It's like what went well before and like I've got like theoretical benefit here, but I'm ignoring all of these potential risks and stuff.
Don't care. Don't care anyway.
I do like having these conversations though with people who are reading more currently and stuff like that, because it means that it makes me check my biases and the reason I make those decisions. Okay, so we've gone through kind of the pre-sinusoidal, sinusoidal. Post-sinusoidal, we're going to have a high protein, but it's going to look pretty similar under a microscope, right? Next transudate. Not going to be many cells. What's the most common cause? So we said cardiac, but what cardiac disease is the most common cause of high protein transudate?
Like CHF, is that what you mean?
Yeah, so right-sided could just
Right-sided, yes, yes.
but what underlying process?
Heartworm can do it. We don't see it here though.
No, that's so true. And I'm sort of saying what's most common, but it's going to be different depending on where you work, isn't it? Yeah. So I'd probably say pericardial effusion.
Yeah, I was thinking pericardial effusion, but the underlying process can obviously be different for so many different causes.
And then the other time we see it is tricuspid, either dysplasia or degeneration. In my experience, in degenerative processes, the mitral and the tricuspid degenerate similar rates, and the mitral's under so much higher pressure that you always see left-sided failure before you see right-sided failure if it's a degenerative process. If there's an underlying dysplasia, which becomes clinical because there's also a degenerative process going on, then you might say right-sided. But yeah, we rarely see that they're the most common two causes of the sinusoidal.
Large clots in the vena cava or compression of the vena cava, that would be post or pre?
Post sinusoidal, yeah.
Post, yeah.
Yeah, exactly.
We've seen quite a lot of like clots thrown to the vena cava that then result in post-sinusoidal.
What do those animals have? Dogs?
Yeah, the one of them had a liver mass as well, so I think something was affecting general flow in that area. And then another just had really, really bad pancreatitis. Yeah.
Interesting. Yeah.
But we have good lots of, access to CT, which enables us to pick up these things, and we're like, would we have ever, we're not going to change anything based on that. And the dog's not necessarily clinical right now, but then you think, I suppose that if there was some acute formation of the clot, perhaps that could explain some of the more clinical abdominal pain in patients that otherwise shouldn't be as painful as they are. I don't know, they're all theoretical.
Yeah.
But I think
we have seen a few of them.
Management may change, because if you have thrombus, then you may want to put this animal on prophylactic thrombosis.
But for those patients, yeah, I definitely agree. But you've often got other factors that might have led you to using those anyway for various other reasons. If it's a Cushingoid patient that also has pancreatitis, then you've got two factors already that mean that maybe you think about using those agents. But yeah, I agree, seeing the thrombus might push you over the edge to actually using it versus just talking about it and then being like, is it really worth it? But it won't help it break down, so it doesn't change that side of the treatment. So
yeah, I would have considered myself a cowboy with thrombolytics or antithrombotics in my day. I've just been burned so many times.
Yeah.
And like these patients, like they've got a clot, you're probably going to put them on like rivaroxaban or something like heparin CRI or something like that would be like the two kind of best choices as far as it being a venous clot rather than arterial and stuff. And they're nice because you can at least partially reverse them if they need surgery. But like a lot of these patients with clots, I'm like, are we going to put a stent in? And I'm going to throw like I'm going to make them bleed out, and it just makes me nervous. I want to be really sure they're not about to need a surgical procedure particularly if I'm using antiplatelet drugs.
Yeah, that's a good point. I think most of the ones that, the few that I can think of were the pancreatitis one actually resolved, but we didn't treat with antithrombotics or anything like that. And the other one went put to sleep. Yes, a giant liver mass.
Oh yeah, sure.
But it wasn't the thing causing it. Like, it wasn't compression of the vena cava. It was a clot kind of adjacent to it. So
yeah, right. So we see portal thrombosis quite often, and that's going to be like pre-sinusoidal. I shouldn't say quite often, it's quite often, but secondary to pancreatitis and cholecystitis, just because it's like that inflammation right next door. and that causes catastrophic diarrhea. Like it's such a disaster. And because there's portal hypertension, essentially you get bleeding into the bowel. You're like, do I put this dog on anticoagulants or not? It's like really hard to know. But yeah, never a straightforward decision. Just yeah. They're cool cases. I don't know. So I think the biggest risk. So I used to work in a hematology lab, human hematology lab, doing my dog research with a human hematology team, which was really cool. And we talked about, because we essentially developed an assay to measure hypercoagulability to be able to quantify it. So all the dogs that came in with clots in the specialist centre I was working in Sydney, which is quite a lot, got my test done essentially, and we could just watch the clot form and see how early the clot formed, how fast it broke down, how long it was sustained for and stuff. Anyway, so then we did all the Cushing's dogs and stuff as well, which was really cool. But dogs are really good at breaking down their clots, which has then made me a little bit more conservative with my anticoagulants as well, because they just find a way to get the blood around it. But the most common cause of clots that we saw was definitely Cushing's combined with being still, particularly in the venous system. And the doctors that I work with was like, why aren't they in their lungs? I was like, what do you mean? And they're like, well, humans,
Where they should be.
Venous clots, they go to their lungs. And I'm like, well, they probably are. They just don't tell us. But like, there must be so much PTE that's we don't just
not diagnosed.
Yeah. And I think, I'm hoping that now that we're using CT more in emergency setting, we're going to pick up more of those PTEs and stuff. Okay, let's talk about Kyle. We don't really see it in the abdomen. We could call it like a lymphocyte-rich effusion in the abdomen. But talking about mechanisms of what causes effusions, Kyle effusion, Kyle's effusion, what's the mechanism there?
And the Kyle flow.
Obstruction.
Thoracic duct.
Yeah, exactly. So it's lymphatic obstruction, essentially. So we can get lymphocyte-rich effusions in the abdomen if there's a lymphatic obstruction. But typically, the lymphatic obstruction is in the thorax. So we see it in the thorax first. So what's the most common cause in cats of chylothorax?
CHF and idiopathic, I think both. I don't know which one is more common.
Is CHF, I think, is above idiopathic, but I don't know. Numbers.
Yeah. And I think, sometimes it's, I don't actually know either. So does anyone know why cats get chylothorax with CHF and dogs don't?
I feel like I looked into this at one point and it's gone from my brain. So I'm not sure. Like,
Ooh, I was hoping you could tell me.
No.
Something to do with the fact that cats are more likely to get diseases that cause biventricular failure. And it can be quite like sudden, that increase in pressure in the bilaterally in the atria can be quite like fast onset, whereas dogs have usually got much more time to develop their remodel their atria basically. And so if you've got a combination of right and left atrial pressure increasing and the cava, the thoracic duct's trying to dump into the cava, then you're more likely to develop a lymphatic obstruction, as opposed to dogs where it's predominantly left-sided and then pulmonary congestion and the right side doesn't actually fail in concurrence with the left side, or very rarely, if that makes sense. So there's the other factor is the anatomy of like the vessels and where the thoracic duct enters. Cats are more susceptible to congestion in there or something like that.
That's the part that I remember, but as much as there was an anatomic difference.
Yeah. And what if let's say, like, obviously congestive heart failure, we treat that with furosemide and decreasing fluid load and congestion. What about idiopathic? What is the risk apart from, like, if we've got a very low grade callus effusion, which isn't causing clinical signs of dyspnea, what is the risk of not managing that?
The loss of your cholesterol and proteins into the chest, like longer term.
Yeah. Do you know what chyle does if it sits around organs?
Probably very irritating.
It's irritating.
It's sticky, yeah. So we've seen like quite a few cases of chronic chylothorax that have just developed really slowly, and they've had no clinical signs, and it might have been there for potentially months. Like the owners might say, "Oh, I just thought they were getting old for like 6 months," and their lungs are like round, so they get this fibrosing pleuritis secondary to it. So not only does the effusion restrict lung volume, but the pleura then restrict the ability of the lung, the compliance of the lungs and ability to expand. So it quite severely impacts pulmonary function. Obviously you can drain the effusion, but you can't take the pleura off. What treatment options are there for minimizing recurrence of chylothorax once you've idiopathic chylothorax?
Surgery,
Surgery?
ductal ligation.
Yeah, ductal ligation. Good. Does it work?
I have not seen too many cases. I'm assuming yes, maybe to an extent. No, from your expression.
So many collaterals. They're sneaky.
Yeah.
Just to tie off the thoracic duct and the other ones
Yeah.
go where I am.
They try and they
Blue
use that,
report then? Do you put a
that
blue report
dye.
and
The methylene blue?
the methylene blue to try and find it, and then I feel like you still can
Yeah.
miss it from whatever.
Well, I mean, how good visualization are you getting?
Yeah.
Like, it's a very tiny area subject.
I don't know how surgeons see most things, so so
Not-
small. I don't understand.
I'm like, open it more.
I can't see a thing. You can use rutin in dogs, but I don't know if it's used in cats, and again, I don't know exactly how effective it is either, but I know that you can use
Yep. Have you heard of pleurodesis? Is that what the word?
Hmm.
So you
Yep.
can actually take a blood sample and then put it into the chest and then rock the animal all around, cover. Yeah. So you stick the pleura to the pulmonary pleura to the like diaphragmatic and
so to prevent it from building up a space for things to get into. I've heard of it, but I didn't hear about it with blood. From when I was reading at the time, it was using some sort of like salt solution, and that was just really scary, and we elected not to do that. But I didn't know about blood, so I'll have to look that up.
The trick is you've got to get the blood in before it clots, I believe. Which is a little bit tricky. Yeah. But yeah, there's definitely published techniques for that online. It's pretty interesting, minimally invasive.
Yeah.
But imagine it would cause a fair bit of pleuritis as well.
It's already got pleuritis at that point.
Yeah, exactly.
But that's interesting. I'll have to look that up. Don't
know. All right. What about, when do we call an effusion hemorrhagic?
Large volume of red blood cells, and then we usually quantify it as well based on the peripheral blood circulation as well, and if it is higher than that, then it's hemorrhagic.
Yep. So they actually like define a hemorrhagic effusion as greater than 1% red blood cells, which is there's a
little bit.
Yeah, there's a lot of exudative effusions where I would expect to see a red blood cell quantified like more than 1%. So it's a little bit tricky if you like kind of don't read your lab report really carefully. Just read hemorrhagic effusion, but then you always want to see or do yourself a PCV so that you can then because then it changes your idea of what the mechanisms are, right? So if you've got a PCV that's the same or higher than peripheral blood, that's like the mechanism is hemorrhage. Whereas when you think it's a hemorrhagic effusion, therefore the mechanism is hemorrhage, what are the other mechanisms of a low PCV hemorrhagic effusion?
So the peripheral, a low PCV. Peripheral.
Yeah, so the effusion has a low PCV relative to the peripheral blood. So say you had a PCV of 5 in your effusion.
really bad inflammation.
Yeah, great.
Yeah.
Exactly. So endothelial dysfunction, right? So if you've got inflammatory causes of that, so vasculitis, I think like probably the most common, like, it's probably going to be defined as an exudate, but like pancreatitis.
Well, you can get from pancreatitis and sorry, you said pancreatitis. Anaphylactic reactions, you can get a full like heme abdomen, and then sometimes
yeah.
So I guess just inflammation in general, you can get hemorrhagic effusion.
Yeah, and we've been in a situation with a really unwell dog who had a heme abdomen, like large volume greyhound, bloody greyhound.
It's a greyhound.
Oh, it's a greyhound. They're really not very good at clotting. So large volume hemorrhagic effusion in his abdomen, but the effusion's PCV was 17 and the dog's PCV was 60. And I was like, this is not
stressful.
Yeah. And it can't be surgical, right? Like it just has to be increased permeability, very increased permeability.
Chronicity will do it too, right? Like if it's just sitting there for a long time.
What will, sorry?
The chronicity, if it's sitting there for a long time.
That's where it gets tricky. So if you've got a bleed that happened 3 days ago, then it could easily have a PCV of 17. And like with anaphylaxis, like there's a lot of breakdown of those red cells. You're gonna get hemolysis, like it's going to be a red effusion even when you spin it. It's not, so I don't, it's not that clean cut, but definitely have anaphylaxis. If the PCV is much lower than the systemic PCV, definitely have increased permeability on your list. And then there's one other cause would be with endothelial dysfunction and increased permeability would be congestion, right? So
yeah, and just perfusion.
Yeah, exactly. If you've got portal, like those portal thrombosis dogs, like it would have been classified as a hemorrhagic effusion because it's greater than 1%, but it was pretty close to 1%. But yeah, portal hypertension, sometimes we see a little bit of red discoloration in that effusion too, particularly if it's acute. If it develops over time with liver failure, not so much. Excellent. What about a septic peritonitis? How are we going to tell the difference between an exudate and a septic peritonitis?
Like if you look at the cells, like you may see intracellular bacteria with septic peritonitis.
Perfect.
And the cell content is really high usually.
Cell content, yeah, absolutely.
Like you'll see inflammatory cells, so you'll see degenerate neutrophils and intracellular bacteria.
I love the theory, but most of the time we see dogs when they've been on antibiotics for a week. And I actually think this is one of the hardest things to call, like septic versus non-septic, and there's and it's surgical versus non-surgical, so it's a big call, right? What other ways?
I mean, from comparing your abdominal to peripheral lactate is good. So that would, and glucose as well, abdominal to peripheral, glucose and lactate.
Yeah,
generally.
So what sort of a difference between glucose peripherally? You knew I was going to ask this, didn't you?
I ask the emergency vets to help me.
So in the septic thing, the peritonitis glucose will be low because your bacteria are using it up compared to your peripheral blood, and lactate will be the other way around.
Yes, good, exactly, because the bacteria.
I just don't know what for example, if your blood peripheral lactate is like 4 and your effusion lactate is like, I don't know what the difference, like how do you classify? So if it's like 4.2, is that relevant?
Yeah.
Yes. Well, this is what, So I think lactate is 1.2. So if the difference is greater than 1.2,
Okay.
And I think glucose
is 20%.
Oh, is it?
Oh, is it 2? Maybe this 2, some 2.
There's a 2.
20% seems like a good number.
Yeah, 20% conservative when you're talking about like the BG's 4.
Yeah.
3.2. Yeah, let's go.
Yeah. I guess you take into I mean, if the question is it surgical or not, you take into consideration the rest of your context and where you think the problem could be, and is that something that's surgically correctable or not?
Yeah.
But depends how much evidence you have, which is not always a
But
lot.
also, like the septic, at least in my head, septic peritonitis cannot linger for a week long. Like the animal will be dead.
Oof.
No,
I think that
Sometimes
there's
because they get
apparently
hypotensive and they like usually they come in crashing. So
they can be like septic, I think, for a lot longer than we give them credit for, technically.
and particularly if they're on antibiotics.
Yeah, and humans apparently, like with a ruptured gastrointestinal tract in various places, they don't even surgically treat those in humans. They just give them loads of it. I know, how crazy.
Wow.
Like for some, like they just give them loads of antibiotics. And then I've seen, I don't know, I guess it depends on I agree, like septic peritonitis makes it sound so bad, but we had a nurse's cat and it's just this chronic issue cat, and it had abdominal effusion that technically was a neutrophilic abdominal effusion, and its numbers looked like it had septic peritonitis, but the cat was eating and bright, and so they started it on antibiotics and sent it home. They ended up culturing salmonella from the cat's fluid, and it had completely resolved. Like on paper it's a surgical abdomen, but the cat was fine.
I have in my head that cats can do primary septic peritonitis, which is different to, so you have primary and secondary obviously dogs do a lot more secondary, and they have like some rupture somewhere most times, but cats can do primary.
Yeah, I think you're right. I don't know
Like I have
where it
something
even
like this in
came
my head.
from. Yeah.
So I think that like very conventional presentation is usually gastrointestinal rupture. So they're so full of endotoxin and so suddenly that they're fully sick. But if you've got, for example, like a duodenal ulcer, which isn't completely perforated, you've just got a little bit of focal peritonitis, or there's been like a little penetrating injury and introduced a tiny bit of bacteria into the abdomen that's not then ongoing, they can actually be sick for ages with septic peritonitis. We've seen quite a few that I've sort of gone, I think it's surgical based on that peritonitis, but we're like practically we're going to have to wait till Monday because there's no one to do surgery. It's Friday afternoon or whatever. Antibiotics in the interim, and then they've either gone in on Monday without rechecking or have rechecked ultrasound and the peritonitis is resolved. So there are examples of septic peritonitis that are not surgical for sure. I had one this dog a couple of weeks ago, and the blood tests were like, it was neutrophilic CRP was 100, like it was clearly very inflamed, but the liver enzymes were completely normal. And I'm looking at this dog and it's got this focal peritonitis, like right cranial quadrant, and it's so septic, like on appearance and stuff. And I'm looking at the ultrasound, I'm going like, there's this like fog of fat, and that gallbladder is like this round and bright wall, and it looks like there's like just cells in it. It looks like tissue. It's so dense. Normal ALP, normal bilirubin. It has this tiny little slip of free fluid that I sampled, and it was septic. And sent it to surgery, and I had a gallbladder abscess with normal liver enzymes.
Wow.
Ruptured bile peritonitis, ruptured gallbladder abscess with normal liver enzymes. How is your bilirubin normal when you've ruptured your gallbladder?
Because it's still going somewhere. It's not building up in the blood.
Yeah.
Far out.
And like maybe liver enzymes are not elevated because it's walled off.
Yeah.
I don't know.
Like,
well, ALP is induced, so I guess if it's very acute.
Yeah.
You still got a 2-day history of being sick.
Interesting.
Wow.
Yeah. I'll go take my kids to school. Sorry.
That's
fine. Thank you very much for your time.
Guys.
Bye.
Nice to see you. Bye.
Bye.